Good afternoon. Thank you all for attending our webinar presentation today on diabetes education programs. Build, enhance, and keep your diabetes education program from ending up on the chopping block. My name is Michelle Hoppman. I'm a registered dietitian and certified diabetes educator, and I'm the director of the nutrition division at DM&A. And along with me today is Allison Ferguson. She is a registered dietitian and clinical nutrition support clinician, and she's an executive success coach with DM&A. We both are very happy to present to you today and to share with you our experience and knowledge of enhancing and really utilizing the resources we have to keep our diabetes education programs running.
All right, good morning or good afternoon, everyone. This is Allison. I know we have people from all over the nation, so I'm sure some of you are joining us at lunch, but welcome. Thank you for attending. Our objectives today are to understand and describe the Medicare benefit for diabetes self-management education or training and put into practice and billing. Now, we'll use DSME repeatedly throughout this presentation as they're used interchangeably, and we often might just use diabetes education instead of saying that. Also, we'll name the procedure codes used to build Medicare for diabetes education, state the benefits to accreditation and or recognition, utilize at least one way to keep your program running successfully, and learn factors about why diabetes education programs are cut, and introduce one or more ways to increase your reimbursement associated with your diabetes education program. Now, all of us are familiar with these statistics, but I find that it's always nice just to have a reminder of the impact that we can make through good diabetes management, because 26 million are diagnosed people have diabetes in the United States, and every 24 hours, over 5,000 more people are diagnosed with diabetes in our country, which is quite amazing. 7 million people in the United States are undiagnosed, and 79 million people currently have prediabetes. 22% of all hospital stays are related to diabetes, and it's the 7th leading cause of death in the U.S. And it's generally the secondary diagnosis of admissions to the hospital. And patients who have new hyperglycemia in the hospital, their mortality rate is 16%. So those are all, I think, motivating factors for us as clinicians to get our patients as well under control as possible. Now, of course, the related costs to our nation are staggering. So a total of $245 billion is the total cost of diabetes in the United States last year, 176 of which were direct, and then 69 billion of which were related to reductions in productivity. And then when you adjust for age and sex differences in our population, the average medical expenditures for those with a diagnosis of diabetes are 2.3 times higher than what it would be in the absence of diabetes. And then diabetes self-management education programs or training programs is obviously a collaborative process through which people with or at risk for diabetes gain the knowledge and skills needed to modify behavior and successfully self-manage the disease and its related conditions. And as we all know, behavior change, lifestyle modification, and self-management techniques are the crucial elements to cost-effective management and care to manage this chronic disease.
Thank you, Allison. And that just really, all of that information just really helps us focus again. As we know, diabetes is very prevalent in our hospitals and in our, well, in the United States. And so it helps support what we're doing every day in our outpatient program. We know that diabetes education is most effective in an outpatient program, and the inpatient setting isn't always the best place to do education, but we end up doing some survival skills there as well. So anywhere that we can impact the patient with diabetes and positively provide knowledge and skills to them to help them manage their disease is important. Just a note, and I didn't mention this at the beginning, but this whole presentation will be sent to you along with the certificate after the presentation is over, so we will be sending that out if you have any questions about that. But we want to know a little bit about what's going on in your current areas. Like Allison said, we have attendees from all over the United States joining us today. And so we're going to do a couple polling questions. We have about 5 questions that we'll ask. So we ask that you respond a yes or a no to these questions. So I'm going to go ahead and launch the first one. And this is about diabetes education programs that you're currently working with in your facility. So I believe the first question is launched. Do you see that, Allison?
I can see it.
Okay, excellent. So we're getting some answers in here. How many of your programs are AADE accredited? Polling is still in progress. We have about 160 people on the line. This is good. Okay, I'm going to go ahead and close the polling, and I will share the results. About 45% of you are AADE accredited. That is excellent. Okay, our next question, of course, is how many of you are ADA recognized in your program? So I'm going to go ahead and launch that question. So go ahead and answer there. I'm guessing it's the other 50%. A few more seconds. So it's about 45% AADE. I'm going to go ahead and I'll be closing the polling here. Get your last answers in. Okay. We'll share the results. So a little over half of you are ADA recognized, which is wonderful. We love to see that. We want to support both of those programs. They're so important. Okay, more questions. Tell us about group sessions. This question here, we want to know if you feel that your group sessions that you're holding within your accredited or recognized programs, you feel that they're successful. They're working really well, no issues. That would be a yes. If there are concerns, issues, you're not really getting turnout, then answer no. We'll leave the poll open in just another few seconds here. Still getting some answers in. Excellent. I'm going to go ahead and close the polling. Okay, we'll share the results. Most of you feel that your group sessions are successful. That's wonderful. When we travel the country and work with different hospitals and different diabetes educators and dietitians, we find that group sessions are one of the biggest areas of challenge. So we will be talking about that today. Thank you for your answer. Okay, so the next question is, how often do the patients that you see complete your whole entire program? So from initial visit through group and follow-up. Good, we're giving some questions there. So it can be, 25% or less, 25 to 50% of the time, 50 to 75% of the time, or 75 to 100% of the time. Go ahead and getting some good answers here. I think most of us are responding. This is good. Our goal, of course, is we want 100% of the people, but as many as we can. Even one visit is better than no visit at all, of course. We're going to go ahead and close the poll. We'll share the results. It looks like the highest result is 50 to 75% of your patients that attend your diabetes program do the whole entire program, which is, I think that's a pretty good turnout. Allison, do you agree?
Yeah, I think that's pretty impressive for certain.
Yeah, absolutely. This is good to see, so congratulations on that. Okay, and I believe we have one more question to ask. This is about the actual visit. So when you get a referral and the visit is scheduled, does your site provide a reminder phone call, text messages? My dentist text messages me and reminds me, as does my hairstylist. So that is a really handy way to work. And then also emails could be a follow-up as well, which we know those reminder phone calls, text messages, and just communication in general do have a good impact on if the patient shows up or not for that appointment. Okay, I'm going to go ahead and give a few more seconds for the poll. Got some more answers coming in here. Only about half of you voted on this one. If there's anybody else who wants to go ahead and note. And some of you guys might not actually have programs, and that's why you're on today, because you're looking into it, so that's fine. Okay, over 60% have voted, so I'm going to go ahead and close that just for the sake of time. And it looks like 70% of those who voted do give those reminder phone calls. Oh, and I didn't share that result, so here it is. So that's good to see. We like to see that. We know that reminder phone calls can definitely help that patient showing up and ensuring that they show up for their appointment and really get the most out of it. Okay, we are done with polling, so I'm going to go ahead and continue on. Thank you for your cooperation in that. It's always nice to see who we have on the call and how many programs we've got out there, and really just focus on the need of our audience. Now, during this presentation, we're definitely focusing on diabetes self-management education, but we're also going to talk a little bit about medical nutrition therapy, MNT. And the reason behind that is we know as clinicians, as educators, that MNT and diabetes self-management training is hand in hand a lot of times. A lot of our patients really need referrals to both. We need that extra nutrition therapy support. So we'll be talking about that today as well. Just a few notes. When we're talking about reimbursement and billing both of these programs, they cannot be billed for on the same day. So if we're seeing a patient for MNT and diabetes, they need to be seen on separate days. And if it's the same provider, so for example, myself as a dietitian, I couldn't provide diabetes education and MNT on the same day and bill for it the same day. But I could see a patient for MNT, bill for that, and then the patient could come back the next day for diabetes. MNT, we know, is very individualized, one-on-one nutrition therapy. It complements diabetes education, and diabetes education is really just an overall education for self-management of diabetes for the group piece. Now, there are facilities and there are groups, education programs that do initial one-on-one as well, and that's an hour that they can use, and we'll be talking about that. So there is some individuality in there as well as we're looking at goals for our patients with diabetes. There are two diabetes education programs that meet the national standards for diabetes self-management education and support, and we asked about these during our polling questions, so it's nice to see the people who answered. About half of you are ADA recognized, and the other half are AADE accredited. And for Medicare, to be able to bill Medicare, you have to have one of these. You cannot bill Medicare, and Medicare will not pay unless you are ADA recognized or AADE accredited. And you know, that also follows suit with a lot of our private insurances as well. Note that when billing, the NPI number of that clinician is the one to be using that is providing the service. So who actually can provide diabetes education? Well, those who can provide the education that are covered by Medicare are registered dietitians. Pharmacies. Now, in this case, if a pharmacy provides it, and we know a lot of pharmacies now are offering this service, they have to be accredited or recognized through the ADA or AADE, but it's actually billed under the pharmacy, not the pharmacist. So it's the pharmacy's NPI number in that case. Physicians can also provide diabetes education, nurse practitioners, clinical nurse specialists, and oddly enough, CDEs are not allowed at this time. However, the AADE, I know, is doing a lot of legislation to pass this, and we support that as well, because it would be great to see CDEs be able to bill. So just on a side note, within your state, see what you can do if you're supporting this as well, to email your senators and your legislators to really support that. There's a lot of grassroots stuff that goes on through the AADE. Who can refer for diabetes education? Now, this is a little bit different than medical nutrition therapy. We know MNT, it's only a physician referral. That's it. And it has to be like the physician that the patient is actually seeing for their primary care. Diabetes education, again, physician that takes care of that patient, primary care. It can't be their optometrist or their dentist, even though in my experience and Allison's experience, we do have, those people who want to refer these patients, but it needs to be their physician they're seeing. It can be a physician assistant, a nurse practitioner, and a clinical nurse specialist. At the bottom of the slide there, I noted that you have to have the signature, and stamps aren't allowed because we do see that sometimes happen. So the signature of the actual provider needs to be on the referral form, which we will be discussing here as well. Oh, the referral form, here it is. So now many of you have referral forms, obviously. If you have a program, you have to have that referral form. The most complete referral form, and the recommended one that we provide when working with our clients in developing diabetes programs and or supporting and enhancing the current programs our clients have along with M&T is the form that's found on the AADE website, and we provided the link below there. So what we're going to do here is I'll show you a picture of that, or a scanned-in version of that form on the next slide, but we'll talk about what's on the form and how important that is. In our experience working with clients across the United States, we see all different types of forms, and just as a side note, when I worked in the diabetes education program out in North Carolina when I first started, we would get handwritten prescription on prescription pad papers, Bob Smith or John Smith, date of birth, to see Michelle, or to see Mary, or to see diabetes, and then they would just sign it. And that would, even though they had a referral form, we still got that in, which was kind of funny because it was great because we wanted them to see us, and then we ended up having to send the referral form out. So we want to make sure that our physicians or providers know how to use the referral form, where it's located, and all the information is complete for ensuring that you're getting your reimbursement from insurance. So all of this information, I'm not going to go through every line, but you see their patient information is important. This is what the actual referral form looks like, and some of you might actually be using this already or have a form of it. It's a PDF on the AADE website, and more than likely what I'll do, I just need to make a note, is I'll send this with the presentation today as a PDF so that you have it at your fingertips. I like this form because it has both diabetes on the left and M&T on the right. So if a patient needed to be referred for both, we have that opportunity there. Plus, if you have a separate M&T referral form and just a separate diabetes one, the physician might, without education, not always grab the right one or not always think, oh, M&T as well. So it helps in basically the selling of the idea to the physician, this patient really needs this nutrition therapy or this diabetes management training. So it's nice to have there. On the form, this is more information and a little bit blown up for you here. It indicates what is needed. And this is important as well when we're thinking about insurance reimbursement. This needs to be checked. If initial group is needed, and the initial in group, then the 10 hours of education, and that's the Medicare benefit. If that's what the physician wants, and that's what we would want for our patients, whether they're been diagnosed for 20 years and they've never had this training or they're newly diagnosed, we want to make sure that we can really maximize the education for them, as we know it's a huge undertaking for patients with diabetes and a lot to learn. So these hours need to be checked. These boxes need to be checked. The special needs part, which is on the form, you can use those 10 hours individually, and you can ensure that this patient is getting one-on-one for the 10 hours instead. However, that's only for special needs that are required there, as you can see. The next one is what's going to be covered. So the content, and this is all part of the national standards of education. And so that's also on the form, which is good because then it educates the person providing and showing them that this is what we'll be covering. And then the diagnosis, that's one of the most important pieces of information. You have to have that on there if you're looking for insurance reimbursement. And the diagnosis, currently we have ICD-9 codes for diabetes for type 1 and type 2. And the way that I copied this from that form, it's kind of formatted odd. But know that those codes need to be written in or typed in depending on how your form is set up. And it's a 5th digit on the code, so we have to make sure that when the physician is sending you over the referral, that ICD-9 code is actually put on there. Some forms have that different ICD-9 codes with the wording on there, and that's fine as well. So they could check a box. But the gestational codes on there as well. And any complications, those would need to be checked as applied. Now, and as of October 1st, 2014, there'll be a new ICD-10 codes that will be available. And the drafts are already out there on the CNSC.gov website of the different codes for diabetes. And so just ensuring that working with your billing department and your physicians that you do have that information, that's very important to ensure that you're getting that maximum reimbursement. And, well, actually just getting the reimbursement, the referral form needs to be filled out completely and accurately. Now, so what is the benefit of Medicare? Part of our advertisement for this webinar was a fact that I learned at AADE in Philadelphia this year, and what prompted us to do this presentation was to look at what are we doing with our programs out there and how is billing going, because we learned that only 1.5% of the Medicare benefit for diabetes education is utilized in the United States. To me, it was shocking. It was unacceptable in a way, because if there's all of that insurance reimbursement opportunity for patients who have diabetes to get the education and get it covered, then it made us take a step back and think, okay, well, how can we provide education to people to help them know how to move forward with whether accreditation or recognition of programs. So keeping that in mind, thinking about your program currently and where you are and just programs in your area. So Medicare coverage. So Medicare will cover diabetes education, of course, that diagnosis we talked about, but the actual diagnosis of diabetes is only based on the first three bullets there. And these are all taken from the ADA Standards of Care 2013. What Medicare doesn't see as a diagnosis is the A1C, greater than 6.5%. It's not recognized by Medicare, even though the ADA Standards of Care has recognized it for the past few years. And so keeping that, bearing that in mind, if on your patient history, they have to have one of those three bullet points there. And we discussed this digit as well. Also, the Medicare benefit, it has to be Part B, and this is an option for the patient when they sign up for Medicare. It needs to be Part B insurance. That's what's covering the diabetes education. So if they only have Part A, it's not going to be covered. They have to have Part B. And it's important, too, to make a copy of their Medicare card. And you might have, I know some programs, you've got admissions people doing all this, but other programs, you're everything. You're the person who's scheduling and calling and seeing the patient and doing the billing. So it just depends on your environment, your facility, and the support that you have. So make sure you have a copy of that card for that patient record, or it's an electronic health record, and then it's updated too as well. Also know that if a patient sees a provider and they bill a CPT code that's related to diabetes, like a physician would see the patient and then they come and see you, that can be billed on the same day, but it just needs to be provided by a different provider than for diabetes education. So the only one that can't be billed on the same day is MNT. What is the Medicare benefit? And we all should know this. It hasn't changed. The only piece that's changed is telehealth, and we'll talk about that at the end of the presentation. But the Medicare benefit is 10 hours education covered within 12 consecutive months. So if I have a referral that I got today, November 21st, 2013, I'm good until November 21st, 2014. It's 12 consecutive months. And next year, then, November 21st, I'll need a new referral if indeed I have a complication or something's changed where my diabetes ICD-9 code might have changed, and that would be for the physician. It's a once-in-a-lifetime benefit. So for those patients who have diabetes, you know, they've had it for like 10 years and might have already had the education, they're going to have to check with their insurance if that's ever been billed. And so that's where you can work with them when scheduling the appointment, or your team, to say, have you ever had this education before? That can help the denial. We do see a lot of times when people have denials for this education, it's because they might not have remembered that they've used this benefit before, or they might not have used it in its entirety, so maybe we only have 5 hours left, whatever it may be. It's something definitely worth looking into so that we can really focus the training and education on what is available to the patient. If they're newly diagnosed and they've never used the benefit, they've got the 10 hours for Medicare patients. And then typically how it's used is 1 hour is initial instruction or an insulin training, and then the next 9 hours would be a group session. So, and a group is defined by Medicare as 2 or more participants, 20 maximum typically, just thinking about the size of our group. And just a note on the group, we do see in our experience with working with teams across the country that sometimes it's hard to get 2 people to show up for a group session at one time. So we're going to talk about within our presentation today, how do we get them to keep coming back? That's the goal, right? And to make sure that our education and our time is well spent and that our patients want to come back. And every additional year after that benefit is used, you have 2 hours of education for diabetes education. And that does require a new referral every year, the 12 consecutive months. Now, just a side note with MNT, it's the calendar year for a referral. So if I have a MNT referral that was written today, I would need a new one January 1st because that's our new calendar year. So keep that in mind. It's 2 different pieces. If you think about that combination referral, we will more than likely have to get a new one. So I guess that's the only downside of using that referral form we looked at, is because it contains both information, we would need an updated MNT piece on that as well. And as we talked about, the 10 hours could be individual if special needs are documented and the physician has documented that on the referral, or if there has been no program scheduled within 2 months of referral. Now, you might be thinking, well, we just never schedule group sessions because we can't get people to come in, or we don't have enough staffing, or the times don't work. But that's where I would challenge you, just for the benefit of that group working together. And what comes out of groups, we know the benefit of people working together, sharing ideas can really help in their management and dealing with the stages of change. But also in your schedule, we know you're all very busy and you have a lot of patients to see or administrative work to do, or you might be doing outpatient and inpatient. Doing those groups and utilizing that benefit is really important, even if you only provide them every 2 months or so. The procedure codes for diabetes education are listed here. They have not changed either. There's G0108 individual and G0109 group, and you can see the definitions there. They are both billed on 30-minute increments. Now, Medicaid has different CPT codes or procedure codes, and but these are the ones for Medicare and private insurance. The MNT Medicare benefit, I did want to throw this in just because it was on the referral form and we wanted to look at this interchangeably. MNT for diabetes and renal disease as non-dialysis renal disease, non-transplant, is noted here. So again, have they used this benefit before? And this is where, it was in 2001, I believe, that all of this started with Medicare providing reimbursement for MNT and diabetes. So some of our patients might have already used the 3-hour benefit, but there's also 2 hours of follow-up in subsequent years that they can use as well. So are we talking to our patients about that? Are we encouraging them if they still, have areas to work on in terms of nutrition and diabetes management? Are we utilizing that? Think about the patients that you're seeing. Why are they not coming in? Why are they showing up? What's working well? And within the MNT Medicare benefit, it's looking at the nutrition care process. And when I was looking at this in my resources and references from the CMS website and the AADE and the EDA website and the Academy, nutrition care process just pretty much sums it up when we talk about the ADIME, the assessment, the intervention, the diagnosis, nutritional diagnosis, evaluation, and treatment. And again, Medicare will cover the diagnosis of diabetes type 1, type 2, and gestational for our patients that would like to receive the MNT Medicare benefit. Again, a physician referral is required, but we can also use this benefit. Patients can use it if they have chronic renal insufficiency, they're not on dialysis or had a transplant. Now, another medical condition of a beneficiary that can be discharged from the hospital after successful transplant within the last 36 months, and they actually can get 2 hours of coverage in that respect as well. So really understanding the benefits for both and what our beneficiaries of Medicare can receive can help you when you're seeing them inpatient, outpatient, visiting with people. What can we do to provide to them? How can we serve them and really ensure that they're utilizing their benefits the best way? And we hope to see this, improve. Now, private insurance-wise, that's the next slide here. You need to know within your state what's covered. And I know our reimbursement representatives through the North Dakota Academy of Nutrition and Dietetics, that is where I am, is in North Dakota, where I'm housed. We have our representatives always looking at this and always working on it. So I'm sure within your state, with your academies, or even with the AADE, you'll have some of this information utilized, and I encourage you to check it out. Because when you're making that appointment with the patient, not everybody has Medicare. We know that a lot of our patients do, but we have private insurance too. So it would really benefit the patient and yourself, of course, to be able to speak to what does their insurance require. Now, if we don't have the time to call, we can at least give the patient those G codes and say, these are the procedure codes that we will be billing. See what your insurance will cover. And if they don't, then ask them, well, what CPT codes do you cover for nutrition, for diabetes? And sometimes it takes one phone call or two, but if they have the time and they really want to know, that's really important to look at, because it helps you then schedule the visits and they're not shocked at a bill that might be coming their way. Remember that referrals are always required for any of these services, and they have to be in your office, in the file, in the computer, in the electronic health record before any visits are taking place. Also know that many private insurance companies do follow suit with Medicare requirements as well. I wanted to add this. I took this information directly from a presentation that I watched, and I noted it on the bottom there at AADE 2013, where the presenter shared a couple things that states are doing to try to get more diabetes education covered, because Medicaid, for example, in 18 states, does not cover diabetes education. So find out if your Medicaid state is covering or not. So I thought this was interesting. Again, we have to advocate for our reimbursement. It helps support our jobs, but also helps support education for those patients with diabetes. So in California, Medicaid doesn't reimburse, but however, some Medi-Cal managed plans, which is their Medicaid for California, does provide diabetes education as part of their covered services. In Florida, they just changed their legislation to include diabetes, defined as outpatient self-management training. So again, what we're talking about today based on the standards, so you'd have to be AADE or ADA recognized, or AAAD accredited, or ADA recognized. Whew, a tongue twister. Idaho, they've been covering it for 15 years. Michigan, local health departments, and that's, again, some of the people on this call today might be from health departments, not just hospital or clinics. Remember, diabetes education programs can be provided by any of the providers we looked at, and it can be one person. It used to be you have to have a nurse and a dietitian. Now it's one provider. National standards, again, is what these states are looking at, and that's, I think, very agreeable, as all of us educators want to make sure that if these programs are approved for reimbursement, that we're following some kind of national standards. In Ohio, there's only one code that they will cover, and it's listed there. It's a procedure code, which is for nutritional counseling, but it's only covered in the physician office. So this is, again, taken straight from a presentation I went to at AADE, and I thought that it was very interesting to see what other states were doing, how we can continue to advocate for reimbursement. And I think there's a lot of grant funding out there right now from the CDC looking at prediabetes programs. One of our clients that works with us has been awarded a grant to look at prediabetes education, and they're being very successful in that. And so definitely looking to see what's available to support your programs. You know, we talk about our patients needing to know their numbers, their ABCs of diabetes management. Well, we too need to know our numbers. And I'm sure a lot of you are tracking data related to your diabetes programs through the ADA or the AADE different software programs, which is excellent. We need to track quality data. A1Cs, are patients meeting goals? Are they checking their feet, that type of thing? Are they achieving goals 95% of the time? Those are some numbers to know, definitely, and we have to have them to remain accredited or recognized. But I'm looking at other numbers, too. So do we know our no-show rate? Some of us do. Some of us might need to go back and think about that. Are we keeping it, is it kept in a formalized kind of process? If we have a high no-show rate for our appointments or our visits, are we double booking, really excited to prepare? Sometimes we know some patients just don't show up, so are we going to double book? And then, or just to kind of pad that, or do we find that that's not going to work and we need to maybe have 2 educators and then looking at in our clinics, you know, what's going to work the best? Are we doing the phone calls? And most of you are doing the phone calls for those who have answered, or text messages or emails. How far are you booking out? Now, pretty much across the country, what we've heard is less than 2 weeks when the referral hits the office. And that we feel is pretty consistent. We don't want our patients waiting more than 2 weeks. Now, there are some populations of diabetes patients that we would want to see sooner, and you guys know who these people are. Our gestational diabetes patients for sure, our type 1 newly diagnosed patients as well need to be seen within a few days of that referral, or definitely, you know, receive a phone call and get them in as soon as possible. Really, I've talked to some clients that, and just some teams just in conversation, that are billing 4 to 6 weeks out. And so if you're billing that, or not billing, booking that far out, you might want to step back and say, do I need more support, or where are we spending our time? Do you know if what's being denied in terms of insurance and why? Are you working with your billing department on that? As a coordinator of your program or a manager of your program, this is good information to have, because you want to make sure that the time that you're spending in the insurance you're billing is being billed appropriately. Sometimes what we see is that the wrong provider number gets put in, the national provider number, and it's not actually, it's the physician one and not the actual provider of the service. What is your monthly revenue for the program? How many hours are you billing out for the actual people that are seen? What's your profit and loss statement? Do you have one? Do you need to work on one? The reason I speak to all of the above, what we just covered, is because in our experience we see administration, especially in hospitals, ask, okay, what's going on with the diabetes program or the M&T program? How much money are they bringing in? How many patients are they seeing? How is it positively impacting our hospital and the goals that we have? Every hospital that we've worked with, hospitals that we've talked to, and you know, in your facility, you're asked to cut, and in your budgets, 2 to 3%, whatever it may be annually. And a lot of times administrators will look at these outpatient programs and say, well, we're losing money on them, let's just not bill. Or how do we make money on them? Most of the time we're not making a lot of money, you're not rolling in the dough, but we're actually breaking even. And sometimes we can make some money, but we don't want to not bill if we're able to bill and we're accredited or recognized, because that doesn't support then the other educators that are legislating out there and having successful programs if we're offering free services. So the best practice is to bill our insurances appropriately, as we discussed, using the best practices to follow with the national standards and what insurance requires, to making sure that we're accredited or recognized and that we continue that accreditation or recognition. Other areas of knowing our numbers, are we looking at, when I say sliding scale here, it's not the sliding scale we're thinking of in terms of insulin. What about our patients that are self-pay? does our hospital, does our clinic have a sliding scale for those who don't have insurance? Do they have a charity care type of program? Some facilities do. And so how can we help them? Because we know that sometimes people will look and say, well, I can't come into diabetes education programs because it's just going to cost me too much. I don't have any insurance. So what are we doing to help support that in our areas? Find out what's happening in your hospital there. Maybe it's a letter of support the physician writes to if they do have insurance and it doesn't cover it, for example. Other performance goals within our organization, are there performance goals that your organization has that diabetes management, self-management training can help impact and speak to as well? And we could also look at readmission and blood glucose control in the inpatient setting and compare it to the patients that we've seen, especially if they're within the same facility. Okay, we're going to talk about scheduling appointments and selling yourself. This is the time where you've got them on the phone, and this is our time to basically sell. And sell, sometimes people think of it as such a negative word, but every day you're selling something. You're selling an idea, a behavioral change that you want your patient to make. You're working with them. What's going to work best for you? So 95% of the effort is them just coming to your office to come and see you, and then that's just the motivation there. It's kind of like going to the gym. 95% of the effort is just getting there and then working out. So we want our patients to come in, and we get the question, well, do I have to? Is this mandatory? Well, your physician referred us to you, so it's definitely highly recommended. It's not a have-to type of deal. So when we think about this, this is an opportunity to ensure that we keep our patient load as high as we need it to be, and that we're scheduling our patients and that they're showing up. So a couple take-home points to look at within scheduling for that first visit, whether it's an initial group or initial one-on-one visit, calling and scheduling them within like 48 hours of getting that referral, keep that momentum going. And yes, this might take some more support staff, but think about how your day is set up. Can you take 20 minutes in the morning and call the patients? And hopefully most of you have administrative support or somebody within a different department that you can look to help you with this as well. When I worked in diabetes education back before my current position, we did all of the scheduling ourselves, and it was a lot to do, and I know a lot of places out there are still doing that. But if we can get them within 48 hours, we keep that momentum going. It's still kind of fresh on their mind. They've already heard about it. They're thinking about it. Have a policy on how many times you're going to call and leave a message. That's another thing we want to think about. I worked with one facility that has a very nice policy on how many times they're going to call and leave. 3 times max, they document it, and then the patient always can call back. But we don't want to also spend a lot of time trying to catch up with people, because not everybody's ready for an appointment right when the referral is written. They might come back to you in a few months, and I know you've experienced that. How are you scheduling the patient? Is the patient going to see you as the educator? Do you have an educator, nurse educator, and a dietitian? Do you each see them for 30 minutes so you utilize that 1-hour benefit? Or do you have the initial visit scheduled and then the next day you're going to start group, or 2 weeks later? Look at how you're scheduling. Remember that momentum, keeping that motivation up. If you have an initial appointment today, the 21st, on a Thursday, but group isn't until after Christmas, we might lose them. But at the same time, giving them a few weeks, maybe 2 or 3 weeks in between, we've seen that work well with their initial goals. So we don't want to really keep between our follow-up or our group appointments any more than 2 or 3 weeks. What topics are you covering when you speak to the patient? Letting them know the physician referred them, and these are the areas that we'll be covering. Is there anything specific that you're interested in learning right now? Is there consistency within your visits? Are there certain areas that you're covering? I'm sure many of you are. Who's making the appointments? And we want to make sure that if we have somebody making our appointments, that we train them, and then we use a script. And we work with teams to develop scripts and build scripts that if somebody that is not a dietitian or a diabetes educator or nurse educator working with them, that they're ensuring that they know how to speak to this. And if there's specific questions, obviously we want to share that with our educators so they can answer them. Same with group sessions, reminder phone calls. physician referrals, this is what we talked about. Let them know the length of classes, so whether you're doing 2-hour blocks, 4-hour blocks, 6 hours at a time. Thinking about that. You know, with group sessions, it looks like plenty of you have success in that. So when we do the question and answer here in a few minutes, I'd like to know what's working really well, and I'm sure the rest of us as well. But in our experience, we've seen that offering the classes at different times of the week, different months. We know not everybody can come to an afternoon class because of work schedules or a morning class, but also remind them that this is, you know, if they're able to take some time off of work to come, that this is a very important piece of their medical care. Keeps them out of the hospital. If you can do any weekend work, that's awesome. I know a lot of us can't, but if we can offer that even every 6 months, you might get in some additional people that you wouldn't have before. Think about if you're doing an 8-hour class, have different speakers. Maybe we'll be looking at pharmacists or nurses or CDEs, but really change it up. I know myself, I would not want to hear me speak for 8 hours straight, but doing different activities and making it really interactive. And the conversation map training, as many of you are probably using, is a good way to be interactive, but we also have to look at the demographic of our group as well. And making sure adults are with adults and kids are with kids, that type of thing. And Allison, did you want to speak for just a moment on the buddy system?
Oh yes, we're running short on time, but the buddy system or the peer-to-peer system, in our experience, we've seen it work really well in certain programs where people will either be paired up or encouraged to be paired up with either someone who's been in the program longer or someone who's also new. But that peer-to-peer, you know, having an appreciation for the potential complications of uncontrolled diabetes and then feeling responsible for someone else who's in the same boat as far as being able to exchange email or phone numbers and ask for advice or say, do you remember what, you know, our speaker said about XYZ, sometimes sharing recipes, going out to eat, that type of thing has been really successful and also successful in getting people to come back because it's not just a relationship with a healthcare provider, it's a relationship with a peer and wanting to see your peer succeed in their diabetes control.
Awesome, thank you. So let's think about maximizing the benefit. We talked about M&T and diabetes education, making sure that if there's an opportunity for a patient to receive both, that we do it. But also, we want to make sure that if we know Medicare more than likely will deny the coverage of the services because they've already used their hours, but the patient says, you know, I definitely still want to move forward with this. It's working really well for me, or you know, it was 5 years ago that I used those 10 hours of education, but I really need it, and I understand Medicare will not pay. Or we might need to explain that to the patient too. Use the advanced beneficiary notice form, and we'll show you a copy of that right here. And I had worked with some people that are using it and some people that weren't at all. And if you don't use it, then you cannot bill the patient if Medicare doesn't pay for it. So that's your advanced beneficiary notice. It's a blank form, and we'll send that out with our PDF information too, but it's also found on the CMS website. If you just type in that bottom form number on Google, you can find it there as well. So you have to fill in why they may not cover it, and that would be, for example, that benefit has already been utilized. Or if you're an M&T patient and you're seeing it for cholesterol, or like high hyperlipidemia, and they have Medicare, then they would need to fill that out if they're planning on trying to bill Medicare for that. Okay, I'm sure a lot of you have heard about shared medical appointments. That's another opportunity to think about how can I really enhance the services that I provide. Our patients see our physicians and they see us, but why not together? And this has been a very successful type of program that can be built. And why is it something that we're looking into? With all of our ways to really motivate patients and the Affordable Care Act, and looking at how can we best utilize services that we provide as clinicians and providers, but also for our patients. So patients are seen more often by physicians for problem visits with diabetes. They're more likely to attend one visit instead of 2 or 3 visits. They'll learn from each other in a shared medical appointment, and that's where the patients or participants would come together, you know, in 2 or more in a group, and they'll be seen by the physician individually or provider, but they'll be educated by the educator as a group. So kind of like a group session, but billed differently. and it reduces the provider and educator no-show rates. So who? Diabetes or M&T patients, participants, definitely. And then also the people who provide the education are CDs, RNs. Oh, I apologize. My reminder popped up. Let me get back to the presentation here. And then places that have done it successfully that I heard about when I was at AEDE was Cleveland Clinic and Sutter Medical Foundation. So you can, if you want more information on that, I can send you some links. But you can just go on the Cleveland Clinic website. They have some good information on there about success. So how to set up a class. And this is something that we could spend a whole webinar talking about, are these shared medical appointments. But if you've talked about them at your facility or utilizing them, definitely one to look into. The patients would check in. You'd download their blood glucose logs or their continuous blood glucose monitoring system information, blood pressure, eye foot screens, that type of thing, labs. You get all of that information from them. You do introductions, have a group session, do some motivational interviewing in there, and do some individual one-on-one sessions with the provider. And this can be separate because they all sign confidentiality forms or HIPAA forms, but they can be a separate room that the patient would go and see the provider for a few minutes. Because you definitely, to be able to bill this under the billing benefits, the provider documents and bill these patients separately or individually, so that means they do obviously need to see them for 5 to 10 minutes or whatever it may be to meet with them. And I put the CPT code on there as the second bullet, or a similar code for a face-to-face visit. And this all came from the AADE website under shared medical appointments. They have a handout on there, and I referenced it at the end. Now, if it was a group M&T visit, then that could be billed under the group M&T code 97804, and it has to be provided by an RD. So another way to enhance what we're doing in our program, a patient might be sold more on coming in like for an M&T visit if a physician was there and they could see them as well. Telehealth and Medicare. Telehealth is accepted by Medicare, and it can be utilized as a benefit if appropriate. It does not include text messages and phone calls, but more face-to-face instruction. So it can be individual or group diabetes services with a minimum of 1 hour of an in-person instruction. So you still have to have that 1 hour of in-person instruction of the 10-hour benefit. And the CPT codes are the same ones that we would use in diabetes education. Same with M&T. We could use telehealth. It was, I want to say 2006, M&T telehealth benefit with Medicare, and then in 2011, the diabetes one came about. But what counts in telehealth? Because we're not working with them, you know, in the same room. That's the benefit of telehealth in like our rural communities. I think about it today in North Dakota here, where we just got 2 inches of snow, and it was kind of blizzardy last night. You know, telehealth would work really well if you don't want to get out and about. But Medicare states that telehealth is an interactive audio or video virtual technology. So Skype, think about Skype or any type of interactive video where they can see the instructor and you can see the participant in real time. It cannot be recorded. If the patient is in one state and, for example, the dietitian is one providing from another state, the education, that dietitian would need to be licensed in both states if the state requires licensure. And then there's a modifier that needs to be added to the CPT code for billing, so you'd work with your billing department on that. What does not count as telehealth is texting, emailing, or phone calls, or chatting, or you know, LinkedIn, or anything like that. So marketing your program, thinking about how you market it, make sure that you have really good marketing tools for your program. And many of you probably have brochures out there already. The information is on your intranet. But if not, or if you've had it out there for like 10 years, is there any way you want to spice it up and change it up a little bit? One of the biggest things that we find in our own experience working with programs, but also when talking to teams out there, getting the word out about your program, actually visiting provider offices, letting them see who's the person doing the education, especially if you're in a clinic or a health department, or if you're in a competing area, know who your competition is out there, and make sure that you provide informational sheets about your program, about what insurance requires. That's going to be something that's very important as well. And then share your success stories. Recently, the program in our area has been in the newspaper a few times. It's an awesome way to market and to share the wonderful work that they're doing. And then also, they've been on the news. So it's good to see patients see that, feature stories, and then also speak to other areas that could, send their patients. And like we said, podiatrists, optometrists, the pharmacies, they can't refer, but they can definitely share information about your program. From the inpatient side, this is some information that I thought I would throw in, a little bit of information about thinking about what we can do to save money and meet goals and help reduce costs and readmission. And so just some notes. This, again, could be a whole other presentation on inpatient blood glucose management. But think about if you work inpatient or if you have CDEs that are working inpatient and outpatient, what are you doing with nursing, with blood glucose control impacting length of stay? What kind of initiatives does your hospital have? What about value-based purchasing and looking at best practice and evidence of care? Looking at readmissions related to diabetes. There's a whole opportunity there, looking at our glycemic control again. Are we working together during rounds, during our interdisciplinary team meetings, and looking at insulin and order sets? Are we getting, reducing the amount of sliding scale we're seeing to get better blood glucose control? And they talked a lot about that at the AADE conference. And sometimes we do use it, but it's not really best practice anymore. And then reporting. There was one team that reported basically a physician's scorecard. Now, this isn't always probably utilized as well, and we would sometimes use it in terms of like the malnutrition diagnosis team in the medical nutrition therapy side, but we can look at results of how your patient is doing it within their control. So to wrap it up, not to end up on the chopping block, know your competition, know your numbers, be able to speak to your program and the success, not just the patient care success, but the financial health of your program. Be able to work with your interdisciplinary team. Reduce your number of no-shows by doing reminder phone calls, really selling your program, getting more people in so that you're seeing patients within a timely manner. Maximize your benefits for MNT and DSME. Make sure your group session is the one that you would want to attend as well. Do we need to change it up a little bit? Do we need to look at the curriculum that our AADE or ADA programs require, and how can we make it more interactive? I just spoke to a group of high school students a couple of weeks ago, and I knew right away I have to entertain the whole entire time, and that was different because that's kind of the, people were constantly needing to be interactive, and it was cool. It's not anything negative, but it was just a different way to look at presenting. So we're constantly being fed information and constantly being entertained. So what can we do to really increase in our group sessions? And then ensure your program management and business skills are sharp and keep sharpening them every day. Here are some of our resources, which you will be getting as well. And we're going to do a quick polling question here, and then take a few minutes for questions. We're pretty much up to the end of the clock, but if you could stay on for a few minutes, we'll get some questions and answers. So the first polling question we'd like to know, and you'll see it on your screen there, but I'm going to launch it, is would you like to learn more about starting a diabetes education program from scratch, like if you don't already have it? And about 45% of the people, so I know a lot of you do have programs, but for those who don't, would you be interested in attending a webinar that gave you some tips on starting from scratch? Okay, I'm going to go ahead and close the voting here in just 5 more seconds. Okay, and then the result was about 42% of you, and I'm guessing that's the other half that doesn't have a program, so that's great, good to know. And then our other question here is there's a procedure code out there, and many of you dietitians know about that. And we are doing a lot of training and educating on this in our clients that we work with, how to utilize basically the obesity counseling, working with the dietitian and primary care provider. And the Academy has a lot of good information on this and a toolkit on that as well, so you can also look that up. But we'd be happy to do a webinar and just discuss that benefit as well. And right now, I mean, 70% of you have voted, and I'm going to close it here in just a few more seconds. Okay, we'll go ahead and close that poll, share the results. It looks like their next webinar will be on obesity counseling with the dietitian and primary care providers. So that's excellent. Thank you for sharing our thoughts. We always like to provide webinars that you are interested in. Okay, let me see here. Oh, here we go. Oops, I went back here. So I just want to share with you our Good to Best conference is an educational conference in San Diego in March, and Allison and I will be presenting there as well. We will be focusing on clinical nutrition teams and how to continue to move forward successfully in the healthcare revolution. And also we'll be providing nutrition-focused physical assessment workshop training, which is a hot topic currently. And we'll be discussing more about reimbursement and the 2 polling questions we just asked you about. So scholarships are available for a conference. It's not just clinical nutrition. It's food service management, education, EDS training. One of the most inspirational and fun educational conferences that you will attend. I will guarantee you that. So if you're interested, check out goodtobest.org. And again, limited scholarships from our sponsors are available for you if you'd like to attend. Okay, Bernard, could we spend about 5 minutes on questions if anybody has any?
Yes, we can. Excellent job, Michelle and Allison. Michelle, can you see the question box? The attendees have sent a number of great questions over the question chat box, and I think we can answer a few from there, and the rest we can compile in an email and send the group all the answers.
Yeah, that would be great.
Also, Michelle, if you don't mind, close the poll screen and then show the information for Good to Best so that the people can see it. No problem.
Oh, I didn't hit that.
So I would take a few questions from the questions box, and then and we'll answer the rest via email.
Okay. I can't. How do I expand the question box? Because I'm not able to expand it.
You should be able to stretch it.
Oh, okay. So just stretch it down. Yeah, I can. Well, it's not stretching down. So well, here we go. Maybe. Oh, there we are. Okay, I've opened it up. So, okay, here's the question. Are hospital bills using the hospital MPI number were considered outpatient in a critical access hospital? Is that okay? We have conflicting information. Yes, that is fine. In that type of facility, if outpatient is under the hospital, that's fine. But also ensure that with a hospital MPI number, that when the bill is provided, that you do have the clinician that provided the education on there as well. Can a registered dietitian with a CDE provide DSME? Yes, but you cannot charge for it. Like insurance reimbursement as a CDE, you cannot. Now, if that registered nurse was a nurse practitioner, they could under their provider number. Can we get copies of the handouts are coming out? Definitely. Just going to see if there's any other questions. Yes. Can a dietitian without a CDE apply and qualify as a provider? Yes. For accredited or recognized diabetes programs. Yes, you definitely can. If a client has not used all the 10 hours in the first calendar year, can they use the remaining hours in the subsequent year? I will check into that, but I believe that is correct. But I need to double check that one there. And we'll answer one more question here. Is 250.00 of course ICD-9 code? Yes, it is. It has a 5th digit, and that's a controlled type 2 diabetes, I believe. I'd have to double check that to make sure. And can you bill M&T for non-diabetes and diabetes on the same day? Well, if you're billing for M&T and it's not diabetes, it more than likely will not get covered unless it's a renal. But if it's non-diabetes, and you still have the patient fill out the ADN form for, because it's cholesterol, like if it's a Medicare patient, then you could bill it on the same day because the diagnoses are different. But I'd want to talk a little bit more about that with that person who asked the question, because we want to make sure that we're following suit. If it's a non-Medicare, the private insurance more than likely will not cover it as well. Bernard, are there any questions over the phone? Are you there, Bernard?
Michelle, I'm
okay.
here.
Okay, great. And then what if here's one more question I'll answer. What if you're not getting information on what's being reimbursed from your billing office? We've asked, and they do not provide this information to us. So I would definitely talk to your direct report and have them go to the person who's over the billing office and speak to the importance of that, because it's a program that you are managing. So again, you should know your numbers in that, or at the very least, the person who's over the whole department. For example, if you're not the director of your department, if you're the coordinator of your program, but you have a direct report, that person should be getting that information and speak to that, because you are the one that is responsibility for the quality outcomes of your program, and you'll be the one that administration says, tell me how things are going here. So I would definitely speak to that and advocate for that information, as they should be providing that information to you. Okay, well, if there are any other questions, feel free to email us. Bernard, if you want to give them an email address, I didn't put one on here. I apologize.
It's no problem. You can email us at, you can reply to the webinar email, webinars@destination10.com, or you can email us at info@destination10.com.
Great, thank you. And we'll be sending out the ADN form, the referral form, and then the presentation along with the certificate today. Thank you, Allison. Thank you, Bernard, and thank you, everybody, for attending. Keep up the good work.